Hello everyone. Today we are learning about hip joint, pelvis and SI joints radiographs. There are few imaging modalities: plain radiography, CT, MRI, nuclear imaging and ultrasound scan. Possible positions for basic X-ray images. AP with supine, usually for hip joints and pelvis, alternatively for sacroiliac SI joints. AP position, usually for hip joints and pelvis, but alternatively for SI joints. PA with prone, usually for SI joints. Due to the shallow obliquity of sacroiliac joints, the prone position allows the diverging X-ray beam to protect through the joint space, giving better visualization of the joint compared to the AP projection. It also reduces the radiation dose to the gonads in comparison with the AP projection. Further, due to tissue compression, the PA projection for SI joint imaging significantly lowers radiation dose compared to the AP projection without compromising image quality. This is sacrum iliac fossa, sacroiliac joints, SI joints. Oblique rays through sacroiliac joints. Patient and equipment preparation. Patient preparation. Ensure that all metal objects in the pelvic region are removed. Ask the patient to remove all clothes in the pelvic region and provide a suitable cloth to wear. The patient should be provided with a clear explanation of the procedure. Use appropriate radiation protective shading for the patient. Equipment preparation. Select the suitable cassette size, usually 35-43 for pelvic and hip joints and 80-24 for the SI joints for adults. These sizes are varied according to the size of the pediatric patient in pediatric imaging. 35-43 for pelvis and hip joints, 80-24 for SI joints. Position the side marker properly and place the cassette correctly in the table bucket tray transversely for pelvis, both hips and SI joints, longitudinally for single hip, transversely for pelvis, both hips and SI joints, longitudinally for single hip. Send the X-ray tube to the image receptor and to the patient and set FFD 100 cm for all these regions. For skull also 100. Then prepare the other useful accessories such as immobilization devices. Select the exposure factors correctly according to the examination and the patient size. Radiation protection measures. For the patient, avoid or minimize the repeat examinations by identifying the patient correctly, giving a proper explanation about the procedure to the patient, following a well-planned procedure, follow the LARA principle, provide leg protective things such as thyroid shields, gonadal shields, eye goggles. Primary beam should be collimated to the area under examination. If the patient is a lady, especially in the childbearing age, ask about the pregnancy and the 10-day pregnancy rule is applied when necessary to avoid the radiation exposure to the fetus. For the radiographer or staff, stay inside the leg cubicle while during the exposure. For the guardians, provide a lead apron, thyroid sheet, condor sheet and eye goggles. AP radiograph of pelvis. What are the indications? Blunt trauma, injuries resulting from an impact with a dull, firm surface or object, or other pelvic trauma. Blunt trauma or other pelvic trauma due to a car wreck, motorcycle or bicycle accident, fall or getting hit by a car as a pedestrian, etc. All these traumas can cause injury to the pelvic bones, including fractures. Target disease. New bone tissue gradually replaces old bone tissue. Over time, bones can become fragile and misaligned. Target disease. Bone lesions. Degenerative diseases. This is the images. This is pelvic fractures. This is benign spotted bones. Paget disease. Severe and symmetric degenerative changes. Position of the patient and cassette. The cassette is placed transversely in the table bucket tray and asks the patient to lie supine symmetrical on the imaging table or trolley. MSP at right angles to the table and coincident with the midline of the table. Adjust the pelvis to bring both ASISs equidistant from the tabletop to avoid pelvic rotation. Both hands should be kept either side of the body or kept on the chest to bring them away from the primary beam. Lower limbs are slightly abducted and internally rotated to bring the femoral necks parallel to the cassette. Lower limbs are slightly abducted and internally rotated to bring the femoral necks parallel to the cassette. Sandbags pads are placed against the ankle region to help maintain this position, and a compression band can be applied over the lower abdomen who has excess of tissues overlying their pelvic bones to improve image contrast. Direction and centering of the X-ray beam. The vertical center ray is directed. Center point is in the midline of the body, where midway between the upper border of the symphysis pubis and the line joining both ASISs. Center point is in the midline of the body, where the midway between the upper border of the ASISs. Collimate the beam properly. Finally, the position of the cassette should be checked to confirm whether the center of the cassette is coincident with the vertical center line of the primary beam, and position of the cassette should be adjusted if needed. Exposure is made with normal breathing to blur out the obvious ball shadows over the sacrum and iliac bones. Exposure is made with normal breathing to blur out the obvious ball shadows over the sacrum and iliac bones. This is the image. See this, the eye goggles, and see the upper limbs rotated inward. Both hands in either sides. Essential image characteristics. Both iliac grades, greater trochanter and the upper third of the femora must be visible on the image. Both iliac grades, greater trochanter and the upper third of the femora must be visible on the image. Lesser trochanter should not be visible. It's the evidence of giving adequate internal rotation of the limb. Lesser trochanter should not be visible. Is the evidence of giving adequate internal rotation of the limb. Region should be centered. Pelvis should be not rotated. The iliac bone should be of equal size and the obturator foramina the same size and shape. pelvis should be retrograde. The iliac bone should be of equal size and the obturator foramina the same size and shape. The optical density ideally should be similar throughout the bones of the pelvis and the proximal femoral. Image contrast must also allow visualization of the trabecular patterns in the femoral necks. No artifacts from clothing, image processing, handling, etc. No movement and sharpness, image blurring should be visible. Then see this image, transverse processes, sacral promontory, greater squatic notch, posterior spine, superior pubic ramus, pubic tubercle, wing, ala of iliac, iliac crest, tubercle of iliac crest, anterior superior iliac spine, anterior inferior iliac spine, ilopubic eminence, pectineal line, articular cartilage. Then obturator foramen, pubic symphysis, pubic arch, inferior pubic ramus, greater trochanter of femur, lesser scatic notch, ischial tuberosity, lesser trochanter of femur. See, this is antero-posterior projection of the whole pelvis with internal rotation of the femur. The lesser trochanters not seen. This is sacroiliac joint, crest of ilium, anterior superior iliac spine, anterior inferior iliac spine, superior ramus of pubis, obturator foramen, ischial tuberosity, fifth lumbar vertebrae, posterior inferior spine, greater scatic notch, acetabulum, femoral head, femoral neck, intertrochanteric crest, greater trochanter, lesser trochanter, femur, symphysis pubic, fovea. This is neutral, lesser trochanters visible. Internal rotation, femoral neck parallel to the facet, lesser trochanters not visible. External rotation, lesser trochanter clearly visible. Then the AP radiograph of both hips. What are the indications? Fractures, dislocations, bone lesions, degenerative diseases to the hip joint. As a post-operative examination evaluating the placement of existing orthopedic devices, development dysplasia, irritable hips, generalized hip pain, arthropathy, a joint disease can be associated with the hematologic blood disorder or an infection. Post-operative flow-up after total hip replacement. THR is a treatment option for late-stage degenerative hip disease, also known as osteoarthritis or degenerative arthritis. As a postoperative examination for sheep capital femoral epiphysis, a disorder of adolescence in which the growth plate is damaged and the femoral head moves zips with respect to the rest of the femur. The head of the femur stays in the cup of the hip joint while the rest of the femur is shifted. Trauma to both hips. Then the position of patient and cassette. The cassette is placed transversely in the table bucket tray. Patient lies supine symmetrical on the imaging table with MSP at right angles to tabletop and coincident with the midline of the table. Both hands should be either side of the body or kept on the chest. To avoid pelvic rotation, the ASISs must be equidistant from the tabletop. Lower limbs are slightly abducted and internally rotated to bring the femoral necks parallel to the cassette. Sandbags pads are placed against the ankle region to help maintain this position, and a compression band can be applied over the lower abdomen who has excess of tissue overlying their pelvic bones to improve image contrast. Direction and centering of the X-ray beam. The vertical center ray is directed. CR is perpendicular to the IR. Center point is in the midline at the level of femoral pulse. Center point is in the midline at the level of femoral pulse. Okay. For the pelvis, what is the center point? Center point is the midline of the body, the line join both the ASISs. Okay. Now, for the both hips, the center point is at the level midline at the level of femoral pulse. Collimate the beam properly. Finally, the position of the cassette should be checked to confirm whether the center of the cassette is coincident with the vertical center line of the primary beam, and position of the cassette should be adjusted if needed. Exposure is made with normal breathing to blur out the obvious ball shadows over the sacrum and iliac bones. Essential image characteristics. Greater trochanter and the upper two-thirds of the femora must be visible. Greater trochanter and the upper two-thirds of the femora must be visible on the image. Lesser trochanter should not be visible. Upper two-thirds of the femora must be visible. Region should be centered. The optical density ideally should be similar throughout the bones of the proximal femora. Image contrast must also allow visualization of the trabecular patterns in the femoral necks. Using compression on appropriate patients who have excess of tissues overlying their pelvic bones can improve image contrast. No artifacts from clothing, no movement and sharpness. Image blurring should be visible. This is the radiograph of both hips. Then AP radiograph of the single hip. Indications: fractures, dislocations, bone lesions, degenerative disease of the hip joint. As a post-operative examination evaluating the placement of existing orthopedic devices, development dysplasia, irritable hips. As a prospective examination for shift capital femoral epiphysis, a disorder of adolescence in which the growth plate is damaged and the femoral head moves zips with respect to the rest of the femur. The head of the femur stays in the cup of the hip joint while the rest of the femur is shifted. Trauma to both hips. Position of patient and cassette. cassette is placed longitudinally in the table bucket tray because of single hip. Patient lies supine and symmetrical on the X-ray table. M must be perpendicular to the tabletop and coincident with the midline of the table. Both hands should be either side of the body or kept on the chest. To avoid pelvic rotation, the ASISs must be equidistant from the tabletop. Affected lower limb is internally rotated to bring the neck of femur parallel to the tabletop, and it is then supported by sandbags. Direction and centering of the X-ray beam. The vertical center ray is directed CR perpendicular to IR. Center point is 2.5 distal along the perpendicular bisector of a line joining the anterior superior iliac spine and the symphysis pubis over the femoral pars. Center point is 2.5 cm distal along the perpendicular bisector of the line joining the anterior superior iliac spine and the symphysis pubis over the femoral pars. Either tabletop should be moved or patient should be moved from the initial position to position the CR over the center point. Collimate the beam properly. Finally, the position of the cassette should be checked to confirm whether the center of the cassette is coincident with the vertical center line of the primary beam, and position of the cassette should be adjusted if needed. Exposure is made with gentle breathing. Gentle breathing. Essential image characteristics. Greater trochanter and the upper two-thirds of the femur must be visible on the image. Region should be centered. The optical density ideally should be similar throughout the bones of the proximal femur. Image contrast must also allow visualization of the trabecular patterns in the femoral necks. Using compression on appropriate patients who have excess soft tissue overlying their pelvic bones can improve image contrast. No artifact from clothing, no movement and sharpness, image blurring should be visible. This is the radiograph of single hip. Fovera, femoral head, femoral neck, intertrochanteric crest, greater trochanter, lesser trochanter, femur or shaft. Then PA radiograph of the SI joints. Indications: fractures, sacroiliac joint dislocations or subluxations, possible inflammation, sacroiliitis of the sacrum and SI joints, ankylosing spondylitis, fusion of SI joints. Position of patient and cassette. The cassette is placed transversely in the table bucket tray for both SI joints now. Patient lies prone symmetrically on the table. Due to the shallow obliquity of the sacroiliac joints, the prone position allows the diverging X-ray beam to protect through the joint space, giving better visualization. Giving better visualization of the joint compared to the AP projection. It also reduces the radiation dose to the gonads in comparison with the AP projection. MSP should be perpendicular to the tabletop and it should be constant with the midline of the table. Adjust the pelvis to bring the posterior superior iliac spines PSIS equidistant from the tabletop to override rotation. Forearms should be raised and placed on the pillow. Forearms should be raised and placed on the pillow. See, sacral base, iliac crest, posterior superior iliac spines PSIS, sacral reticle. This is a sacral iliac joint, pelvis bone, PSIS. PIIS. Sacral coccyx, ischial tuberosity, pin. Direction and centering of the X-ray beam. CR is directed to a point in the midline at the level 1.5 cm below iliac crest at the level of PSIS, 1 cm 5 below to the PSIS. Even though only one joint is affected, both joints are imaged for comparison. If only one joint is affected but both joints should be imaged for the comparison. Center is angled 5 to 15 degree caudally. This angulation is dependent on the sex of the patient. The female requires greater caudal angulation of the beam. The first angulation we have found. Okay. Center is angled 5 to 15 degrees according to the sex. Female requires greater caudal angulation of the beam. Collimate the beam to include both SI joints laterally and the entire sacrum superiorly and inferiorly. Entire sacrum superiorly and inferiorly, both SI joints laterally. Finally, the position of the cassette should be checked. Then exposure is made with gentle breathing. Sacrum, iliac fossa, sacroiliac joint, vertical. This is the image. Right SI joint, left SI joint. Right SI joint, left SI joint. Normal posterior anterior projection of sacroiliac joint. See, sacrum, ilium, left sacroiliac joint, right sacroiliac joint, superior auricular process, sacral foraminals, left sacroiliac joint, apex. Then AP radiograph of the SI joints. Indications: fractures, sacroiliac joint dislocations or subluxations, possible inflammations, sacroiliitis of the sacrum and OSI joints, ankylosing spondylitis, fusion of the SI joints. Position of the patient and cassette. The cassette is placed transversely in the table bucket tray. Patient lies supine symmetrically on the table with MSPs perpendicular to the tabletop and it should be coincident with the midline of the table. Adjust the pelvis to bring the ASIS equidistance from the tabletop to avoid rotation. Hands should be kept on the chest or either side of the body and knees should be flexed to give a better contact with the relevant region by eliminating the lumbar arch. Direction and centering of the X-ray beam. Center point is midway between the line joining ASIS and the superior border of the symphysis pubis. Center is angled 5 to 15 degrees cranially. Depending on the sex of the patient, the female requires greater angulation of the beam. This is cranial angulation for the AP. of SI joints and caudal angulation for the PA of SI joints. Collimate the beam to include both SI joints laterally and the entire sacrum superiorly and inferiorly. Finally, the position of the cassette should be checked to confirm whether the center of the cassette is coincident with the vertical center line of the primary beam, and position of the cassette should be adjusted if needed. Exposure is made with gentle breathing. This is the AP image of both SI joints. Normal anteroposterior projection of sacroiliac joints. Joint spaces are not clearly seen as they appeared on PA image. Make a joint spaces not clearly seen. In the AP, spaces very clear on PA position. But in AP, the spaces are not clear. Okay, today's lecture is over. We will meet with another interesting lecture in next day. So, thank you all everyone. Goodbye.